Hi, I'm Rainer Hochgatterer, orthopedic surgeon from Linz, and in this video we will be performing an MCL reconstruction using a 100% allograft suture anchor called shark screw suture. I'm excited, so let's get started.
The patient, male, 71 years old, undergoes surgical treatment due to a complete rupture of the medial collateral ligament of the left knee, resulting in grade 3 instability. Additionally, both a medial and lateral meniscus tear are present. Following supine positioning, a team timeout, and sterile preparation, the procedure begins with arthroscopy. In the suprapatellar recess, a pronounced synovitis is noted and treated with a partial synovectomy using a shaver. The femoropatellar joint space appears normal and patellar tracking is central. In the medial compartment, there is grade 2 to 3 chondropathy of the medial femoral condyle and grade 2 chondropathy of the tibial plateau. The posterior horn of the medial meniscus shows degenerative changes with fraying and a complex tear, which is debrided using a punch and shaver. The anterior cruciate ligament appears elongated but intact. Medial joint space instability is clearly visible during intraoperative examination. In the lateral compartment, a complete tear of the lateral meniscus is present without associated chondropathy. This tear is also debrided. After completing the arthroscopy and evacuating the irrigation fluid, a skin incision of approximately 7 centimeters is made over the medial epicondyle. Under tourniquet and meticulous hemostasis, the medial collateral ligament is exposed. At its femoral origin, the ligament is completely torn, especially in the deep layers. Following anatomic exposure, temporary fixation is performed using a 1.6 mm K-wire to assess isometry, which proves satisfactory. The 1.6 mm K-wire is then exchanged for a 1.2 mm guide wire. Sequential drilling is performed using shark screw drill bits up to the black 4.2 mm drill. A thread is then cut into the bone. A shark screw suture, 5.0 mm, reinforced with fiber wire, is inserted and securely anchored in the cortical bone. Care is taken to maintain suture tension throughout insertion and to align the anchor precisely along the drilling axis. The anchor is typically inserted smoothly with minimal resistance. The torn ligament ends are crossed, looped multiple times, and tied down under tension for proper adaptation. Stability testing confirms a stable knee in extension as well as at 30 degrees and 60 degrees flexion. The wound is closed in layers: fascia with vicryl, subcutaneous tissue with a continuous suture, and skin with an intracutaneous suture. A LEA is administered and a soft tissue dressing is applied. Post-operatively, full weight bearing is allowed as tolerated, in combination with a DonJoy brace. Week 1 to 2. Range of motion, 0 to 30 degrees. Week 3 to 4. Range of motion, 0 to 60 degrees. Week 5 to 8. Range of motion up to 90 degrees.